عليكم أبنائي وبناتي طلاب المرحلة الخامسة في كليه الطب جامعه تكريت. محدثكم الأستاذ المساعد الدكتور مهند حسام الكميت، اختصاص الجراحه البوليه. My first lecture is about the congenital anomalies of the upper and lower urinary tract. In this lecture I'm going to concentrate on the most important points regarding these anomalies. First, regarding anomalies of position and number. In position of the kidney, when we said this is the normal position of the kidney, we means the lumbar position of the kidney. The abnormal position, it happens when the kidney is not in its normal site. For example, when it is pelvic kidney, it's in about 90% of cases, the kidney is situated in the pelvis. This is regarding what is called the ectopic kidney. So the ectopic kidney, it means abnormal position of the kidney. Abnormal lie of the kidney, it means the abnormal orientation of the kidney. The normal lie of the kidney, they are usually parallel to the psoas shadow, to the psoas muscle, and parallel to the psoas shadow on the normal KUB. While when they are parallel to the vertebral column, or they have an abnormal lie, this is regarded as abnormality in the lie of the kidney. Another example of ectopic kidney is the thoracic ectopia. It represents less than 5% of cases, and they are present because of a defect in the diaphragm, because of delayed closure of diaphragmatic angle with overshoot of renal ascent. The adrenals may or may not be ectopic because, as we know, the embryological origin of the adrenal differs from the kidney. The kidney is originated embryologically from the union of metanephric blastema and urethric bud at about 4.5 weeks of gestation. Another example of ectopic kidney is the crossed ectopic kidney with effusion. In about 90% of cases, the upper pole of the crossed kidney fused with the lower pole of the native one, of the original one. Therefore, the crossed kidneys are almost always lower than the normal one. And for the ureters, they both end on their normal side. Another example is the horseshoe kidney. The horseshoe kidney, however, its incidence about 1 to 400 live births. They are usually they are united with the connective tissue between them, sometimes containing a calyceal system. This is called the isthmus. When the horseshoe kidney is suspected on IVU examination, when, as I said, they are parallel to the vertebral column, or sometimes the lower calyx faces medial and the upper calyx faces lateral. So when we see these pictures on IVU, the lower calyx faces medial and the upper calyx faces lateral, there is a high suspicion of horseshoe kidney, and we can be quite sure with the use of CT scan. Because with the CT scan, we can detect the presence of isthmus between these two kidneys. It is a quite common condition in patients with Turner syndrome, about 60% of patients, and about 20% in patients with trisomy 18. And one of the commonest anomalies presented with the horseshoe kidney is the PUJ obstruction, pelvic junction obstruction, about 1/3 of cases. What prevents the normal ascent of the kidney hair to its normal site is the vascular structure, which is the inferior mesenteric artery. Now, regarding anomalies of number, we have bilateral renal agenesis, so present in each one live birth for each, or stillbirth for each for each 5,000 live births, and unfortunately they are either stillbirth or they will just pass in the first few hours postnatal life. The majority of them presented with what's called the Potter facies. I mean the facies of the fetus, of the newborn or the fetus, like an old facies, old age facies, like a wrinkling of the foreskin, hypertelorism, low setting of the ears, and etc. These features are not specific or pathognomonic for bilateral renal agenesis, but they indicate severe affection during fetal life, like a severe renal or hepatic disease during fetal life. Another example is the unilateral renal agenesis. It presents about 1 to 1,250 live births, approximately, and they are usually discovered incidentally for any other reason other than the absence of the kidney. For example, patient complaining from abdominal pain, and they usually do the ultrasound, discover that the presence of only one kidney. Or sometimes during examination of the patient complaining from or having a history of infertility, when we examine the vas deferens, we can notice the absence of the vas deferens unilateral with the absence of the kidney. So this association, the absence of the vas with unilateral absence of the kidney in about 80 to 85% of cases. And this association because as you know, the embryological origin of the ureter and the vas deferens are the same. They are both originated from the ureteric bud. Now, another example of anomalies in number is the supranumerary kidneys. It means the presence of more than 2 kidneys, like presence of 3 kidneys. When we mention the third kidney, you should realize that the third kidney having an isolated capsule, isolated blood supply, and they are usually situated lower than the normal and the native kidneys. For the third kidney is usually non-functioning and causing obstruction to the outflow of urine, like causing maybe a cause of PUJ obstruction, for example. And only 100 cases has been reported all over the world with the 3 kidneys. For the 4 kidneys, there are only 4 cases has been reported with this anomaly. We should also differentiate this anomaly from the duplicated kidneys. And duplicated kidneys, we mean the kidney having only one capsule outline, and only the calyceal system could be completed with complete duplication or incomplete duplication, like a bifid, for example, renal pelvis, or bifid ureter, or sometimes with complete duplication. This is a quite common condition, not like the presence of supranumerary kidneys, 3 or 4 kidneys. For the inherited cystic diseases of the kidney, this is what is called the autosomal dominant polycystic kidney disease. As you know, this is inheritance is autosomal dominant on chromosome 4 or chromosome 16, and the most common presentation during the adulthood, and is one of the commonest causes of admission for dialysis, patient with end-stage renal disease. It is about the third most common cause after the DM and hypertension, to account for about 10% of all cases admitted for a patient with end-stage renal disease. The presentation usually for between the age of 20 to 30 years of age, complaining the patient at birth usually have normal kidneys on examination, and on ultrasound they are both have homogeneous kidneys, normal size with homogeneous kidneys. While at the age of 20 to 30 years of age, the kidneys start to grow with hundreds of cysts of varying sizes occupying the parenchyma of the kidney. The problem is that these, as I mentioned, one of the commonest causes of end-stage renal disease. So the fate usually of these cysts is to end the kidney with end-stage renal disease, and the patient will be uremic. How the patient come to you complaining? Usually the patient may have different presentations, like complaining from abdominal pain, for example, recurrent UTI, stone formation, hematuria or heavy proteinuria, and features of renal impairment. The patient may complain from a mass, loin mass, sometimes even a huge size kidney, sometimes reaching or occupying the area from the kidney down to the pelvis, for example. How we can, or what we should do, what's your work to deal with those patients? With those patients, we can start dealing with simple investigation, like, for example, urine analysis. We notice the presence of pus cells, like indicate infection, hematuria, red blood cells, and even cast indicate, for example, also renal affection, and crystals may be associated with stone formation. Also, with the blood urine nitrogen, we notice an elevation in the renal indices. Starting with simple non-invasive test, we can start with ultrasound. Ultrasound demonstrates the presence of cyst, multiple bilateral kidneys. A very important thing, how we can differentiate polycystic from a multicystic dysplastic kidney. And polycystic should be bilateral cyst of varying sizes, occupying, as I said, the renal parenchyma. Also for bilateral, for the adult polycystic kidney disease, sometimes the cyst, including also the liver and the pancreas and the spleen and the aneurysms and the brain also. What's your work, or what's your work, how to manage those patients after we establish the diagnosis of adult polycystic kidney disease? We advise the patient to change his lifestyle, to control blood pressure, control hematuria and proteinuria, and to avoid the use, the ingestion of purines and like red meat and large beans, for example, and to monitor the renal indices. And the final step in the management, we should advise the patient to prepare himself for transplant. This is the final and the definite management of this disease. Also, there is another condition, rare, is called autosomal recessive polycystic kidney disease, inherited on chromosome 6, and it is infantile type. For those patients, usually they are presented at birth with huge size kidneys, about 12 to 16 times normal. Those are usually incompatible with life. And about 100% of patients, they passed in the first 2 months of life. For unilateral multicystic dysplastic kidney, what's important here is to know that this is the second most common cause of a palpable soft mass during childhood. The first most common cause is the PUJ obstruction. The second one is the multicystic dysplastic kidney. And this condition is almost always unilateral, because if it is bilateral, it is incompatible with life. What's the cause? Is usually due to faulty union of connection between metanephroblastema and ureteric bud, resulting in a multi-cyst of different sizes occupying the renal parenchyma, and there is no renal function of this kidney. However, they are sometimes associated contralateral renal genitourinary abnormalities in the contralateral side. For example, vesicular reflex may present in about 20% of cases. This condition is usually treated left to undergo spontaneous involution, and there is no need for intervention in this condition. What are the indication here for intervention? If we notice that the child have mass increasing in size or become symptomatic with severe pain, but the child is having screaming attacks, or a child sometimes complaining from recurrent hematuria, gross hematuria. There is evidence of a gross proteinuria or heavy proteinuria, or when there is a risk of malignant transformation. So these are the indication for intervention patient with multicystic dysplastic kidney. One of the important objects in neurology, in fact, is the polycystic, is the pelvic junction obstruction. It is the commonest cause of abdominal mass in children. I mean a soft mass, a hydronephrosis, which is the commonest mass, a hard mass during childhood. The commonest hard mass during childhood is the Walm's tumor. And what is the commonest mass during the neonatal period? It is the neuroblastoma. In PUJ obstruction, the etiology, we have to classify the etiology into two types: the PUJ during adulthood and PUJ during childhood. The etiology during childhood is due to either segmental muscular attenuation or malorientation or a true stenosis. It means absence of the muscle coat or absence of innervation or a true stenosis, or sometimes extrinsic compression, sometimes presence of folds. This is what is called the Osling folds, and these folds usually disappear after in life, after in the postnatal life. While for the adulthood, the causes are usually due to aberrant vessels. As you know, the presence of the accessory lower pole renal artery in about 6% of cases. And this accessory artery may cause obstruction to the renal pelvis, and in the adult, it usually causes presentation in the adulthood, not in the childhood. Another cause is the retroperitoneal mass or retroperitoneal fibrosis. The associated with the other side, in about 5 to 10% of cases, the PUJ are bilateral in about 5 to 10% of cases. The presentation is usually different. The child is usually presented with a flank pain or a mass or a hematuria, infection, nausea, and vomiting, sometimes uremia. An infant's flank mass may be the only sign where the other older child may exhibit any of the others, like gastrointestinal distress or poorly localized upper abdominal pain. What's important here is how to establish the diagnosis in patients with PUJ obstruction. As we mentioned earlier, we can start with simple tests like urine analysis and demonstrating presence of either pus cells, red blood cells, crystals, protein in the urine, and also we have to detect the renal function, and then with the ultrasound, how we can differentiate the PUJ obstruction on ultrasound and differentiate it from a multicystic dysplastic kidney. On PUJ obstruction, the cyst, there is usually a central cyst surrounded by peripheral cyst. The central cyst here is regarded to us the pelvis, the dilated pelvis, while the peripheral cysts are the dilated calyces. And in multicystic dysplastic kidney, the cysts are usually they are haphazard distribution and occupying the whole. They are not organized. And in order to establish the diagnosis, we have to perform IVU examination. In IVU, we have different features, starting from simple into more severe type of the PUJ obstruction, like there is increase in the size of the renal pelvis, enlargement of the renal pelvis. There is a delay in the excretion of the contrast. There is sometimes ballottement, what is called ballottement of the renal pelvis, like a ballottement of the head of the baby during labor. There is loss of normal cupping of the calyx, loss of normal convex shape of the calyx, and more straight calyx in shape. And then later on, there will be clumping of calyces. And even in advanced cases, there may be absence of the kidney or non-visualization of the kidney. And these are the features, in fact, of the PUJ obstruction. And in cases of absence of the kidney, what we have to do, how we can prove that this kidney is non-functioning, we have to use what is called the isotope scanning. We have two types of isotope scanning for use clinically. The dimercaptosuccinic acid, DIMSA scanning, and MAG3, mercaptoacetyl triglycine. DIMSA is excreted usually by the glomerular secretion, and usually they detect renal function, while MAG3 is usually secreted by tubules, and they usually detect the obstruction, the severity of obstruction. So by them, either one of them, we can detect the renal function or detect the severity of obstruction. When the function is less than 10% on isotope scanning, this is usually regarded as non-functioning kidney and it requires no correction. So how we can prove the diagnosis? By using isotope scanning, and even nowadays we can use what is called the dynamic enhanced MRI scanning. For the contrast, it requires to reach the renal pelvis 593 seconds to reach the renal pelvis. If we see the contrast on the renal on the pelvis area and the pelvic area, this is regarded as normal if it is in less than this time, less than 593 seconds. This is called dynamic enhanced MRI scanning for detection of the PUJ obstruction. Now the treatment here for the PUJ obstruction is always surgical. We have different types of surgeries. Either we have an open surgery, what is called this surgery for the correction of pyeloplasty in general is called pyeloplasty, and we have what is called Anderson-Hines pyeloplasty or dismembered pyeloplasty. Why it is called dismembered? Because it requires excision of the area of the PUJ, excise the area of the PUJ, and reanastomose the upper ureter with the area of the renal pelvis. And this is called Anderson-Hines pyeloplasty. We have other types of pyeloplasty, but these are beyond your scope. We must have certain criteria for the correction of this area of PUJ. For any successful ureteric surgery, we should have several criteria. First, we should do spatulation. Spatulation, it means anastomosis with a wider portion. I mean, I cut in the part of the after I transect this area, and then I should make an incision, for example, an anterior in the pelvis, and with a scissor about 0.5 cm, and a posterior in the ureter, 0.5 cm posterior wall of the ureter, and then re-anastomose them with a wider margin. And this is in order to avoid stricture. So this is called spatulation. The second point is we have to do stent. I have to put stent in the form of double J catheter. As you know, double J is an example of ureteric catheter with two J ends in order to keep the double J in its place and prevent its migration up or down. And this double J function is to ensure complete urinary diversion, and we have multiple fenestrations for them to also to reinforce this function, and it also maintain a patent caliber and prevent a fistula formation, which is as you know, the fistula it's a connection between two epithelial surfaces, for example, between the ureter and the outer skin. So in order to prevent fistula formation, to prevent stricture, and to accelerate healing, I should put a double J catheter for repair during any ureteric surgery. The third important point is the trimming. I should do trimming until reaching the healthy ends. And fourth point is the tension-free reconstruction. You should reconstruct the ureter without tension. And another point is we should use always absorbable stitches. And the best stitch here to use is the polyglycolic acid stitch, or commercially known as Vicryl. Now, so this is the example of open surgery. For the minimal invasive surgery, we can use what is called the ureteroscope with full thickness incision in the area of the upper ureter, the left part of the ureter. Why we do incisions in the left upper part of the ureter? Because the blood supply here to the upper part of the ureter comes medial. So I shouldn't do incisions on medial side of the ureter. I should do the incisions on the lateral side and put a double J catheter there. Made a full thickness incision and put a double J catheter. And the success rate of this procedure is about 80%, while for open surgeries it is about 98%. A third procedure is using of balloon dilatation. Now, thank you for your listening. This is the end of part 1 of my lecture. Thank you.